All right. Well, thanks for having me. I hope everyone's having a good symposium thus far. And I've been asked to talk about young onset Parkinson's disease. So I imagine there are some in the audience today who have this or have had this for a long time. So just a disclosure, I was paid as a consultant by AbbVie, who makes Duopa. And what we'll talk about today is we'll define what young onset means. How young do you have to be be young onset? And then we'll spend most of the talk talking about some of the differences between young onset Parkinson's disease and a more typical age of onset for Parkinson's disease. And that'll include some talk about the genetics of Parkinson's disease, as well as some of the differences in motor symptoms that can occur, some of the differences in non-motor symptoms, and then how treatments can be a little different, and some of the impact on social aspects of life. And just as is the case in all people with Parkinson's disease, some of the things I'm going to talk about are general trends, but everybody's Parkinson's disease is unique, so not all of these things necessarily apply to everyone. So this is a graph here talking about, or kind of showing the incidence of Parkinson's disease in different age groups. And what we see here is that young onset Parkinson's disease is typically defined as less than 40 years of age. Some researchers have defined it as less than 50 years of age. And so both definitions are used. And as somebody gets older, the incidence of Parkinson's disease becomes much more common. And we have a group here of late onset Parkinson's disease, which is defined as over the age of 70. And that the remainder is called middle onset Parkinson's disease, which is the majority, but these are much larger groups, whereas young onset Parkinson's disease is not quite as common. This is a more complicated diagram here, but ultimately shows for females and males how what's called prevalence of Parkinson's disease, which is a little different than incidence, but it's basically how many people are alive in that decade that have Parkinson's disease, and that also rises over time. And so it's about 100 times more likely that somebody in their 70s or 80s is going to have Parkinson's disease compared to somebody in their 40s or 50s. So this is kind of a summary here of some of the differences seen in young onset Parkinson's disease, and kind of divided as to whether that might be better than regular Parkinson's or kind of worse. So one thing that's favorable about young onset Parkinson's disease is overall tends to have a slower progression, and that involves a lot of the more disabling features of Parkinson's disease, and that would include slower onset to having any sort of falls, slower onset to any cognitive impairment, and slower onset to any difficulty with swallowing. People are generally healthier and have less other medical problems when they have Parkinson's at a younger age, and that often improves their function. And then there is a greater longevity after the diagnosis, where people from diagnosis to passing away tend to be a longer period of time. Whereas on the negative side of getting Parkinson's at a younger age would be that often there is a longer delay to diagnosis. People tend to think about it less, when people present with symptoms, and sometimes it presents more with things like shoulder pain or foot pain, and so it can be more of a challenge to diagnose it. And then there is a higher rate of genetic cause. So Parkinson's is due to a combination of genetic and environmental factors. Well, the younger you are when you develop Parkinson's, there tends to be more of a genetic influence. And then there's a higher rate of motor fluctuations. And if you're not familiar with that term, we will talk about that in more detail. There tends to be more dyskinesia and tends to be of a more disabling quality. And we'll also talk about what dyskinesia is. Because somebody is at a different life stage when they develop young onset Parkinson's disease, there can be a greater loss of income and a greater impact on their family or career. And then there does tend to be greater mental health burden and a greater loss of life expectancy. And I'll kind of, these two things may seem to be at odds, but I'll talk about that in a bit. So this is just a table maybe for your review, but these are things that are less frequent or less severe or come later in people with young onset Parkinson's disease. So maybe we'll talk a little, just kind of introduce how Parkinson's disease is staged. So prior to diagnosis, people often do have symptoms that don't involve movement. And this is called prodromal Parkinson's disease. So this might be things like acting out one's dreams or constipation or depression, and then eventually get diagnosed. Then there's this early stable period where people often have a pretty good response to medications. And then over time, people can develop these motor complications, including wearing off or dyskinesia. And generally speaking, in young onset Parkinson's disease, there may be a greater time period before these develop, but maybe not. And then eventually people may develop, they're called levodopa resistant symptoms. So these would be symptoms that aren't really responding to some of our typical medications for Parkinson's, things like some people have, often you develop a balance problem where the medicine really doesn't resolve that, or things like swallowing where the medicine really doesn't help with that. And this would more be referred to as late stage Parkinson's. But once people develop motor complications, that is called advanced Parkinson's disease. That's maybe not the best term there, but what is, when we say young onset Parkinson's disease has a slower progression, we're really referring to this late stage Parkinson's disease where these levodopa resistant symptoms and cognitive issues tend to come, further out from the diagnosis. So those might be more like 20 to 30 years after diagnosis. When we think about longevity in Parkinson's disease, the average life expectancy for the average American is about 78 years old, and you might add 2.5 years if you're a female and subtract 2.5 years if you're a male. And how does age of onset of Parkinson's disease affect that? Well, maybe we'll look here at late onset Parkinson's disease first. So somebody who's diagnosed after the age of 70, they're going to live an average of somewhere between 9 and 10 years after diagnosis. If you were to compare that to somebody else who's in their 70s, who doesn't have Parkinson's disease, it's very similar time, and really not really a difference there. And so Parkinson's disease is really not affecting life expectancy in those patients. And let's look over to the young onset Parkinson's disease. Well, after diagnosis of Parkinson's disease, somebody with young onset Parkinson's disease is expected to live considerably longer than somebody with late onset Parkinson's disease. But if you compare them to somebody without Parkinson's disease, it does have an impact on their life expectancy. And so I think it is common for doctors to say, Parkinson's disease doesn't affect quantity of life, more quality of life. I think that's not always true, and that the younger you are, that when you develop Parkinson's disease, there can be a life expectancy shortening. To talk a little bit about Parkinson's disease genetics, this is a complicated topic, and I can't get into too much detail on it. But people with so looking at kind of just anybody in the general population over your lifetime, for men, if you live long enough, you have a 2% risk of getting Parkinson's disease. For women, that's 1.3%. And then if you have a close relative, so that would be a first-degree relative, either a parent or a sibling, with young onset Parkinson's disease, you're going to multiply those by 7.8. So, for example, that'd be about 15% for a man who had somebody who, let's say their brother developed young onset Parkinson's disease, they'd have a 15% chance of having Parkinson's. Whereas if it's late onset Parkinson's disease, that still is higher, but not to the same degree. And some of the common genes I've just listed here. We don't really have time to get into how these might look different. These affect kind of how our cells process proteins, or how some of the powerhouses of our cells work. And these would be things that can be tested for. So I think it's a complicated question as to who needs testing, and I don't know that we have a great answer for that. But even in somebody with young onset Parkinson's disease, if we were to test all those patients, most of them would not have an identifiable gene, on this list. And both for cost reasons, as well as it not directly changing how we manage patients clinically, often it is not done. But testing is done through a blood test, and can be pursued for patients that are interested. For Parkinson's disease motor problems, so all of these motor problems are common in all types of Parkinson's disease, but the ones I put a red box around are ones that are more common in people with young onset Parkinson's disease. And we'll talk some about limb dystonia, dyskinesia, and motor fluctuations, which are when these symptoms fluctuate, over hours or days due to variability in the treatment effectiveness. So to talk a bit about motor problems in Parkinson's disease, so a normal dopamine system would consist of dopamine production down here in the midbrain, and that would then be transported up and used in what's called the basal ganglia up here. And you could think of this as sort of gasoline, which is the dopamine being used up in the engine of the brain. And in a normal dopamine system, the engine works well. Well, what happens in Parkinson's disease is that gasoline factory, or the dopamine factory, isn't working as well, and so our engine kind of runs out of gas, and we get these movement-related problems. And then when we treat Parkinson's disease, we add dopamine to make up for the lack of production, and that is used by our engine, and it helps improve symptoms. And in early stage Parkinson's disease, that is often given 3 times a day. And even though the medication kind of fluctuates in people's bloodstream, people feel good throughout the day, and there's no ups and downs on the medication. Well, when we transition from early Parkinson's disease into what's termed advanced Parkinson's disease by the onset of motor complications, we get motor fluctuations, we can get dyskinesia, and often people have to take medicine more frequently. Why does that occur? So we can go back to our diagram here, and something I hadn't put in there was this little storage facility for the dopamine that we add to somebody's system. In early stage Parkinson's disease, you're able to store that medicine to be, and your brain can kind of release it as it needs it. Well, in advanced Parkinson's disease, that storage capability is not as good. And so, when your brain can no longer temporarily store the dopamine, your medications are more likely to wear off. And now, due to some oversensitivity that the brain develops to try and make up for the lack of dopamine, your brain can go into overdrive and cause these extra movements called dyskinesia. And the end result is that people become more dependent on us delivering the medications steadily over time. So, this might be what happens as somebody moves into advanced Parkinson's disease, is that if we keep that medication dosing the same, at the peak of a medication dose, people might get these extra flowing movements, and then a period of time after the dose, the medication may wear off, where some of the symptoms of Parkinson's reemerge, and we call these clinical states off periods where the symptoms come back, and on periods where the medications are working. And then if you're having dyskinesia, we call it on with dyskinesia. And this is a video here of dyskinesia.
So those were the three changes. Get rid of the amantadine, decrease the neuropex from Pexel, and increase Gistalevo. Sequentially, we didn't do these things at once. And the wheelchair certainly is no longer needed at all. And you were pretty much confined to a wheelchair most of the day, weren't you?
Yeah.
Can they tell me about your thinking and memory again?
On the right side of their body, as you see more dyskinesia, usually on somebody's more affected side. So that would be a typical example, in contrast to, the symptoms of Parkinson's disease. Sometimes people call this shaking. Well, the tremor of Parkinson's disease, which I'll show you.
99, 98, 97, 96, 95, 94, 93, 92, 91, 90.
Of a movement. So that there's an example of what dyskinesia can look like. And with motor fluctuations, the typical pattern is that the off periods tend to occur at the end of a dose. It may take a while for your off symptoms to improve after you take a dose, just due to a lag in absorption, but and then they reemerge at the end of a dose before your next dose is due. These are often gradual in onset, but can become more sudden over time. And that the dyskinesias occur at the peak of a dose, but there are some variations to that typical pattern. These sudden off periods, or sometimes people randomly get off periods that are not at kind of predictable times. Sometimes people have a weaker medication response at the end of the day. There can be what are called dose failures, where somebody would take a medication and it really just never seems to kick in. Or people can develop dystonia, which we'll talk about in a second here, that develops during an off period. And then it's fortunately less common, but can occur where people get dyskinesia both in when the medicines are too high and too low, and that can be very difficult to manage, and often requires things like deep brain stimulation. And I think it is important to recognize that people can have what are called non-motor symptoms of off periods, where not only can they have difficulty moving, but can have other symptoms that come when their medicines wear off. Most commonly would be anxiety, but might include pain or a feeling of restlessness, feel depressed or fatigued, feel cloudy, have trouble concentrating, or just feel like everything's wrong or panicked. There can be sweating or bloating in the abdomen. People can feel like it's hard to catch their breath or suddenly have to urinate. So these symptoms can certainly occur with not related to medication fluctuations, but if there are kind of periods of time where these are occurring and you can correlate them to your medications, medication adjustments can sometimes solve these issues. And so I've mentioned dystonia. This is what it is. So it's an involuntary movement, and it's caused by excessive muscle contraction where the brain is telling these muscles to be overactive. It often results in abnormal posture and might be painful. And the most common way this would happen would be in the foot, where the ankle kind of bends downward and inward and the toes curl. And there could be pain either in the toes or the bottom of the foot commonly. Might be more common as somebody walks or exerts themselves. It also tends to occur during off periods. It also can occur at the peak of a dose of levodopa, or it can involve sites like the neck or hand. And commonly those do not occur during off periods and are more consistent feature. And how you would treat this is, if it is occurring during an off period, you try and eliminate those through medication adjustments. You can add medications that help with muscle relaxation, and these are amantadine, baclofen, or Artane are commonly used. If it's just one area, you can inject something called botulinum toxin, or often referred to as one of the brands as Botox, into the muscles that are overactive. And then in certain patients, deep brain stimulation surgery may be the best option for them. So kind of switching gears is how would treatment be different for somebody with young onset Parkinson's disease? Well, I think maybe in two main ways. One would be that commonly practitioners try and spare the amount of levodopa that's used in somebody with young onset Parkinson's disease, not necessarily avoiding it altogether, but trying to use more of the longer acting medications that we have for Parkinson's. Those would include dopamine agonists or amantadine. And that's to try and provide this steady benefit throughout the day. As we know that patients with young onset Parkinson's are more likely to get these ups and downs with medication. And then for similar reasons, patients with young onset Parkinson's disease would often be good candidates for deep brain stimulation if they're interested in that sort of therapy. This is a complicated table here, and we won't go through this in too much detail, but basically we'd be often using any of these medications in addition to carbidopa, levodopa, for patients with young onset Parkinson's. And if we look at how much they help some of the movement symptoms, levodopa tends to be more effective, whereas some of the dopamine agonists like pramipexole, ropinirole, or roticotine tend to be a little less effective. But what's good about them is that they're longer in duration, but do have more side effects associated with them. So look a little more closely at that. Some potential upsides to dopamine agonists would be that they're longer acting, so that you could have decreased amount of fluctuations. They're less potent in inducing dyskinesia. But they do have some downsides. So they have some unique side effects where somebody could suddenly fall asleep or develop impulse control problems or develop leg swelling. And then you are more likely with these medicines to develop some of the side effects that also can occur with levodopa, things like hallucinations or daytime sleepiness, or a lightheadedness or nausea. And then sometimes if somebody's been on a dopamine agonist for a while, it can be hard to get them off of it, and they can develop kind of a withdrawal syndrome from the medicine. Just to talk a little bit more about impulse control disorders. So these are very common with dopamine agonists, or maybe rephrase that. They're usually seen in somebody on a dopamine agonist and not as common in people who are not on a medicine like that, but seen in about 10 to 15% of people with Parkinson's. And this would be where somebody can't resist pulses or temptation, and might involve gambling or hypersexuality, like either an increased need for sex or often kind of an obsession with pornography. You might have difficulty controlling your eating or shopping, or become overly engrossed in a hobby and can't be pulled out of that. So it's important to look for this and recognize it when it occurs, and realize that it can be related to the medication. And often our first step would be to reduce or stop that medication. And occasionally adding an antidepressant can help curb this problem. And then deep brain stimulation, the main advantage of this is that it's going to be a 24/7 treatment and be very steady throughout the day. Often people are able to reduce medications and the associated side effects that can occur with those. And it's a very potent tremor controlling therapy. It also tends to help dyskinesia quite a bit, but it's important to realize it's not a cure. Also, people with young onset Parkinson's disease tend to have less cognitive issues and less comorbidities, so they're often very good candidates for this treatment. And the non-motor symptoms that are more common in young onset Parkinson's disease are depression. And so to talk about that, depression has both chemical and situational causes, and often these two things are both contributing to why people get depressed in Parkinson's. But dopamine plays a central role in that, as well as a chemical called serotonin that is often deficient in the brains of people with Parkinson's disease. Substance abuse has a chemical impact on the brain, and is more common in people with young onset Parkinson's disease, and can be a very difficult problem to solve. And then chronic pain can also change the chemical makeup of the brain and lead to depression. Whereas situational things like coping with the illness, so initial diagnosis and sort of acceptance of Parkinson's disease is often difficult in patients who are diagnosed at a young age. And then as disability occurs, coping with that is difficult as well. And if somebody does not cope well with it and get resources to help them cope with it, it often leads to anger, and sometimes that anger leads to some self-destructive behavior. So we really try and help people cope with these diagnoses as it can help improve their outcomes. There often can be a sense of shame about the diagnosis and the disease, or a sense of guilt towards feeling like a burden to their family or to their care partner. And that can lead to a loss of autonomy, where you're more dependent on people, and a feeling of decreased self-worth. and put a lot of stress on a relationship, and all these things can kind of add together to cause people to be depressed. And trying to deal both with the chemical problem and the situational problem, I think, is more effective than just focusing on one. And so these would be some of the common kind of ways we would help somebody with this. Would be to make sure that they're not having those fluctuations, which can cause increased anxiety. We often use antidepressants. Working with psychologists to help with the coping process, or counseling for any relationship difficulties. And we try and empower people with treatments that they're in control of, things like exercise, or some strategies that involve changing the way we think about the illness, or getting them involved in community, which we know can have a lot of support, play a big supportive role. I think a typical view of how diseases impact people is to start with biological and then work out from there how some of the biological changes in the brain lead to abnormal behaviors, which then influences how we think about all of this. Whereas we have learned that we can work the other way, where sometimes changing the way we think about the illness and changing some of our behaviors can actually influence the biology. And I'll talk a little bit about that here. One way would be to increase meaningful social activities. We know that can increase self-worth and actually have an influence on some of the chemical problems in somebody's depression. And trying to work through some of the physical limitations that might limit their activities. We know that exercise is incredibly beneficial for people with Parkinson's disease, and these are some of the recommendations about how we would like people to be exercising. But there's just an overwhelming amount of evidence that exercise has wide-ranging benefits for people with Parkinson's. And what type of exercise? Really, we want you to do something that you enjoy, and you're more likely to stick with it and really derive benefit if it's something you enjoy. And all these things have been studied and shown to be beneficial. So the Wisconsin Parkinson's Association has a great resource to look for Parkinson's exercise activities in your area. And then there are some other non-pharmacological ways to manage anxiety problems or sleep that are listed here. And then thinking of kind of changing the way we think about Parkinson's can have a beneficial effect where there's often a tendency to have negative thoughts about somebody's function, and trying to reframe that and not or recognize some of these patterns that we might have, where we think overly negative thoughts about ourselves can really improve things. And often working with a psychologist on this would be the way to learn these techniques. And now we'll talk about some of the social impacts on family, on intimacy, and on the career. So the Parkinson's can present a big challenge for relationships between the patient and their care partner, and it's going to be an enduring challenge over your lifetime. And there's a lot of uncertainty, and uncertainty is very difficult to deal with. Over what the future will hold, and it's hard to not let that worry consume you, but trying to not let it consume you can be helpful. Trying to find that right amount of focus on Parkinson's, where you're paying attention to it and not ignoring it, but also not letting it kind of dominate your life. And some of the path forwards that I found helpful for patients and their care partners is to educate yourselves together about the disease, and to try and keep an open communication even on difficult subjects, like intimacy that we'll talk about here. Look ahead to some of the upcoming challenges that you expect and try and plan. And then try and find some support networks outside of just your relationship, so that you can find support in other means. Some unique aspects to young onset Parkinson's disease would be how to tell children about the diagnosis. I found a kind of a quote from an expert on this who said, "It's often better to direct energy used to keep Parkinson's a secret into coping with the demands of maintaining a marriage, making a living, and raising a family." And so, it's generally recommended that you tell children and use kind of simple language, but also allow them to realize and know that you're going to be okay, so that you don't cause them too much worry. And then patients can get pregnant with Parkinson's disease, and often the outcomes are very good, in terms of the baby. So, if you are of that age and desire to be pregnant, it's best to tell your Parkinson's doctor prior to trying, as we would often alter the medication regimen to make sure we weren't doing any harm. And then there can be an impact on sex and intimacy. That's for complicated reasons. So there can be a change in a typical spousal relationship to more of a patient and a caregiver, or there might be a change in attraction level or perceived desirability, and there can be either decreased or increased libido, or actual problems with sexual performance, either erectile dysfunction, difficulty reaching orgasm, or motor problems interfering. And any of these can lead to a loss of intimacy. So treatment would be multifactorial, where you're trying to address what issues are leading to that, and sometimes broadening that idea of what sex is. Sometimes just like laying with each other can provide a sense of intimacy that is still satisfying for couples. And sometimes people seek out some marriage or sex counseling, and that can be quite helpful. And here's a resource for you from the Davis-Finney Foundation. They have a manual called Every Victory Counts, and there's some worksheets here. And these can help with kind of how to frame a conversation by having both the spouse and the patient fill out a self-assessment of the relationship. And it might help you have conversations on some of these difficult topics. As far as career, I think often this is kind of individualized, but as to when to tell an employer, I think the overarching recommendation is to meet with an employment attorney first, so you can understand some of your protections from the American with Disabilities Act, and make sure that you're doing that in the best way possible to protect yourself. And as to how long you can or should work, usually we encourage people to continue working as long as they're able, to provide that good financial base, and it also provides a sense of worth. But you want to look at some of the demands of your job, and kind of meet with a financial advisor, or if you're considering disability, meeting with a disability attorney can often be quite helpful. And two laws protect people with with Disabilities, the American with Disabilities Act, which in order to be protected by it, you do have to be considered disabled, and this is the definition here. So you do have to have substantial limitations on some of your major life activities. So just having Parkinson's disease is often not enough to qualify as disability. It has to be impacting some of your activities. But the ADA provides protections by requiring employers to make reasonable accommodations as long as it doesn't cause undue hardship for the company. And then it also prevents the employer from negatively considering your disability in some of their decision making, like whether to hire you or not, or fire you, or demote or promote you. And there are resources to navigate this process. One thing that sometimes people are not aware of is that you have a benefit called an employee assistance program through your employer. So this would be when you sign up for benefits, something that is included with some employers, but there's free legal advice, and I would encourage you to utilize this as it is confidential. Whereas if you were to go through your human resources department, that's not confidential, whatever you share with them, or you could hire an independent employment attorney. And then the FMLA, a lot of people are familiar with this, but this requires employers to protect your job if you take unpaid leave for medical reasons, or for a family member's medical reasons. We'll maybe skip over that, but that's just a Social Security disability requirement for Parkinson's disease or another Parkinsonian syndrome. It's important to think about how, if you were to stop working, how you're going to maintain medical insurance, and these are some of the options there. And then we'll talk about some of the further resources, so hopefully you're familiar with some of the resources of the Wisconsin Parkinson's Association, but there are some other national resources that I want you to be familiar with. So the Parkinson's Foundation actually is currently doing what's called an expert webinar series on young onset Parkinson's disease. So I want you can sign up at parkinson.org, and that would be a great talk. Sure, sorry.
No, you're fine. The good news is I'm going to tell people the resources you have listed on the next couple slides, we will post your slides to our website in the very near future, so they'll be able to see those other resources that you offer, and then they can directly click on them and learn more about those resources. But in the interest of time, there's been a few really good questions posted that I want to ask you. So first of all, before I jump into that, thank you so much for your time, and thank you for the presentation. We get requests all the time for early onset or young onset Parkinson's disease, and I think you really hit a lot of the questions people had. So I appreciate that. So the first question I had was somebody who said, if I'm diagnosed and I don't start carbidopa-levodopa until a couple years into my diagnosis, am I losing effectiveness as if I would have started it as soon as I was diagnosed?
No, I think that carbidopa-levodopa will still be as effective if you wait to start that. If you're having bothersome symptoms, during those 2 to 3 years that you are waiting to start the carbidopa-levodopa, that could have been controlled with the carbidopa-levodopa, that would be a negative to waiting, but the medicine would be just as effective if you started it later compared to earlier.
Okay. One of the other questions, it's kind of a specific question, but I think the gist of it is a good one. I was diagnosed 10 years ago at the age of 20. Are there any treatments available now or on the horizon that may be more beneficial to me, seeing that I'm so young with my diagnosis?
Yeah, so I think there are medications on the horizon that that may be more beneficial. So there are medicines like infusion of carbidopa-levodopa through the skin that is currently being studied. There is a infusion of a medicine called apomorphine that's similar to carbidopa-levodopa that has been available in Europe that we are hopeful will be available in the United States in the next few years. Mainly those would improve upon symptom control through being a more steady option. So if you were to be having movement fluctuations, that could provide you additional benefit. And then there are other avenues of research looking into something that will slow or stop the disease process. That's something we have not had for Parkinson's disease, but we're all hopeful that one of these avenues of research will be able to discover that. And so as to how that's probably a little further out on the horizon, but we're hopeful of that.
Okay. In one of your slides early on, you talked about the risk or prevalence of Parkinson's going up if you have a relative with young onset. One of the questions here was, I was diagnosed in my early 20s. Does my sister, who's younger than me, have a greater risk of Parkinson's even than that number that was shown in your slides? Or is it the same as if I was diagnosed in my 40s?
That's a good question. I don't know that specifically has been studied. It has been looked at as if you're diagnosed at the age of 20 versus the age of 40, the likelihood that it is genetic or that you carry genetic factors goes up. So in that way, I think you could presume that probably that risk is even higher for somebody diagnosed, close to the age of 20 compared to the age of 40. But I'm not aware of anyone that specifically looked at risk to other family members based on exact age of diagnosis.
I appreciate that. It's a very good answer. Probably answers the question the person posed, hopefully. One of the other questions we had is, I'm early onset, I've started my medications, I'm noticing I'm having double vision. Is that part of Parkinson's, my medications, or maybe there's something else going on?
So that can be part of Parkinson's. People can get double vision where some of these movements where the eyes move in when we're reading or move out when we're looking at a distance can be impaired. It is not a common side effect of medications, but if the medications are causing a degree of sleepiness or fatigue, it might make it more likely for that to occur. So I can't say that it couldn't be related to the medications, but would not think of it as a typical medication side effect, and more likely related to Parkinson's.
And then the final question I think I'll ask you that has been kind of put out there, what are the different challenges faced by a care partner or a parent when somebody is diagnosed at a younger onset? I know usually when we talk about care partners and the stuff Ruth covered yesterday and Dr. Schoenberger will cover tomorrow, we usually focus on maybe the spouse or other family members, whereas some young onset, I think we're probably focusing parents and other care partners. And what are those challenges different that you see that you would maybe discuss, I guess is the best way to put it.
Okay. Yeah, I mean, I think so. If somebody's diagnosed, you know, either in this, let's say the early 20s, it would often, kind of be the parent that would take over that kind of caregiver role if that patient needed it. And I think some of the challenges would be, perhaps they had not financially prepared for to be supporting, another person. I think often is difficult to see, your child struggle with something like this, or if they were to develop depression, to struggle with something like that. So I think that's a good question. I have not encountered that situation quite as much, so there might be some aspects there I'm missing, but I think it would have some different financial kind of concerns, or just sort of the anguish of a parent watching your child struggle. That would be very difficult.
Thank you very much, Dr. Finseth. I know I greatly appreciate you taking your time to do this. I'm sure our audience appreciated based on the questions that came in. They definitely got a lot out of it. So I appreciate you joining us today and really tackling this topic for us. With that, I'm going to hand everything off to Gary Garland, our executive director. He is going to wrap us up for the day, provide a little insight, and then also remind you to join us again tomorrow. So with that,